A very good evening to all my CCI colleagues, mentors and teachers. This is more than 100 plus webinars conducted by CCI till date, and I must really congratulate the founder member Dr. N.H. Krishna for his vision and all the team members for the execution of these events. We are blessed to be updated in the various topics covered under pulmonology, including the interventions which are possible. And today we will be dealing on non-invasive ventilation and acute respiratory failure. With the current pandemic, I would say NIV has been used like never before, not to take away the fact that it has been our bread and butter when it comes to acute exacerbation of COPD. Its role is very well established in hypercapnic respiratory failure, like in COPD, as also in cardiogenic pulmonary edema, in addition to the various medical therapy which is available, used simultaneously. But it has a controversial role in hypoxic respiratory failures, considering the heterogeneity of the disorder, considering the various severity of the disorder. So most of the times it's very important for us to recognize the narrow window of opportunity for initiation of the NIV. But at the same time, we should also be sure and watching really skillfully for the signs of non-invasive ventilation failure, so as to prevent a delay in initiation of endotracheal intubation as well as invasive ventilation. Thirdly, it is of utmost importance for us as healthcare workers and our team, so as to prevent the viral transmission in the various viral infections related ARDS. Hence, to deliver the master topic, we welcome the master himself. He needs no introduction. His name signifies that he is the king of oration and academics in pulmonology in India. So I welcome Dr. Rajadhar. Sir is the director of pulmonary medicine at Fortis Anandpur, Kolkata. He had been working for quite some time in the United Kingdom, but the call of the motherland, and he is with us, and aren't we blessed? He heads the teaching program in the same institute, and I don't have to tell you about his oratory skills. Before I hand over to Dr. Rajadhar, I would like to once again thank Team CCI and also Team CIPLA for ensuring the technical support for all our webinars. Over to Dr. Rajadhar, sir.
It gives me great pleasure to join all of you in this CCI meeting today. For this masterclass, I'm going to speak about non-invasive ventilation as an important tool in your day-to-day practice. I want to start off by congratulating Dr. Krishna and all the other members of CCI for having come together on a platform where youngsters, the general chest physician, has a face and can interact with others and get their academic interests fulfilled. I would like to thank the entire CCI team for having put me on this platform for a masterclass on non-invasive ventilation. I've been given a total time of an hour. I will try and finish in about 50 minutes, and hopefully there'll be a little bit for everyone. Dr. Krishna has asked me to keep this talk as basic as possible. So we'll start off with basics, and then hopefully even for the experienced chest physician, there'll be certain things which might come in useful in your clinical practice. So we have divided the talk into these subtopics. So I'll talk about how to set up non-invasive ventilation. We'll then talk about our bread and butter, your bread and butter, which is hypercapnic respiratory failure. We'll talk about where there's controversy, which is the hypoxic but non-hypercarbic respiratory failure, what's been termed as type 1 respiratory failure. You know, hypercapnic respiratory failure is type 2 respiratory failure. We'll talk about heart failure and the use of non-invasive ventilation. And a talk today cannot be complete without talking about COVID-19. So I'll briefly touch upon the use of non-invasive ventilation in the COVID-19 pandemic. So let's start off with the basics. So the important first point is, who do you actually offer non-invasive ventilation to? So for non-invasive ventilation, from a symptomatic perspective, you have patients who have respiratory distress. So when we talk about respiratory distress, it's people who are dyspneic, who are using the accessory muscles of breathing, and who have an abdominal paradox. So paradoxical movement of the chest and abdomen is what you look for when you think about acute respiratory failure. The next question is about signs. And in signs, you have two grades of respiratory rate to decide about selection criteria for NIV. If your patient is hypercapnic, so the type 2 respiratory failure scenario, a rate of more than 25 per minute would generally be an indication for non-invasive ventilation. If your patient is hypoxic without being hypercapnic, a rate of more than 30 per minute would be what you would call as being tachypnic. So we have talked about respiratory distress. We have talked about respiratory rate. The third bit is talking about the arterial blood gas. So if your patient has a pH of less than 7.35 and a PCO2 of more than 45, so we are talking about the respiratory acidosis scenario, and then a PO2 which is less than 60, and this would equate to a saturation of less than 90%, or a PF ratio of less than 200. Remember, the PF ratio is the PO2 divided by the oxygen given, the FiO2. So the PF ratio of less than 200 would be an indication for non-invasive ventilation. So any two of the above four, so clinical parameters based on symptoms and signs, respiratory acidosis, or hypoxia, which might be defined on the basis of PO2 and on the basis of PF ratio, all of these together encompass the selection criteria for non-invasive ventilation. When we talk about indications, chronic respiratory failure in the background of having obstructive lung disease, especially COPD, would be important. We'll come back to this in greater detail, and we'll keep repeating a few things over and over again, including this bit, but I think that's relevant because it helps to drive home the points which are simple yet important. So in the perspective of obstructive lung disease, if a patient is fatigued, if the patient is dyspneic, and we defined what dyspneic is in the previous slide, and if the patient is hypersomnolent, so a sleepy patient indicates carbon dioxide retention, that would qualify in the category of chronic respiratory failure. Respiratory acidosis is defined again, so pH of less than 7.35 with a PaCO2 of more than 55. However, if the PaCO2 is between 50 to 54 millimeters of mercury with saturations of less than 88% for more than 10% of the monitoring time despite oxygen supplementation, that would be a criteria for NIV in the scenario of chronic respiratory failure. So this is complicated, so I'll spend a minute again on this. So respiratory acidosis, either Barndo respiratory acidosis with a pH of less than 7.35 and a PCO2 of more than 55. And if the PaCO2 is below that, so between 50 to 54, you have to have saturations of less than 88% for more than 10% of the monitoring time, despite giving the patient adequate oxygen. When we talk about chronic respiratory failure, when we talk about hypercapnic respiratory failure, COPD is not the only cause. It's by far the commonest cause, but not the only one. So thoracic restrictive diseases, so diseases like kyphoscoliosis, for instance, or causes of cerebral hypoventilation can also result in type 2 respiratory failure or acidotic respiratory failure. Patients with this condition have more of fatigue, there's morning headaches, hypersomnolence, nightmares, enuresis, and like the COPD scenario, the patient will be dyspneic. However, you can see that the dyspnea here comes lower as compared to the other symptoms, which are mainly related to carbon dioxide retention. So the symptoms are more from CO2 retention as compared to hypoxia. Even if the hypoxia is present, it's normally prolonged, and patients tend to adjust to the hypoxia in scenarios, especially of thoracic restrictive disease. The same happens to a similar extent in cerebral hypoventilation disorders. The ABG will show a PaCO2 of more than 45, nocturnal saturation of less than 90% for more than 5 minutes, sustained, or 10% of the monitoring time, again, is the selection criteria for NIV in this category of patients. And signs and symptoms of cor pulmonale, so the ankle swelling, the raised JVP, all of these features will also be a part and parcel of thoracic restrictive disease and cerebral hypoventilation. So signs of right heart failure are present in this group of patients. So that's the second criteria, the second category of patients with type 2 failure. Even though this is the smaller category, it's also important to remember this category when you encounter someone with type 2 respiratory failure. The next question that I've often been asked, which is why I have put this in, is where can you give non-invasive ventilation? Let's start from the bottom and go to the top. So the first indication is with intensive care. So patients very unwell with a pH of less than 7.25 and a PF ratio of less than 200 will likely need intubation, and hence in this category of patients, non-invasive ventilation, if used, is mostly a bridge to intubation and mechanical ventilation. A small number of patients might actually get out just on non-invasive ventilation, but the mental preparedness to ventilate this patients invasively if required is something which needs to be present in this category. So intensive care only for pH of less than 7.25 and a PF ratio of less than 200. Next is patients who need NIV, but the same can be done in a non-ICU but monitored bed. So this is patients with a higher pH, so a pH of less than 7.3 and a PF ratio of 250. So this is patients between with a PF ratio of around 250, ballpark between 200 to 300. This category, however, would normally get away without invasive mechanical ventilation if you manage to give non-invasive ventilation in a proper manner. So these are moderately hypoxic patients, and probably the PF ratio between 200 to 300 and a pH of between 7.25 and 7.30 is the most important category for non-invasive ventilation, because you can avoid invasive mechanical ventilation and all the associated complications that come with intubation and ventilation in this category of patients. The third category, where non-invasive ventilation can be given on the ward, are patients with a pH of between 7.30 and 7.35. These patients are only mildly hypoxic with a PF ratio of about 300, and here mostly NIV is successful. This is where ideally NIV should be initiated, and it prevents progression in almost the entire number of patients to whom this is offered. So remember these three categories: the categories where non-invasive ventilation can be initiated on a ward, on a monitored bed, be that a high dependency unit or a respiratory care unit, and third, the intensive care unit. And remember the numbers of pH and the PF ratio that we have spoken about. How do you start non-invasive ventilation? Now this sounds easy, this sounds uncomplicated, However, this is where most non-invasive ventilation fails. And I will dwell on for the next 2 or 3 minutes on the initiation of NIV. If you start well, it is more than likely that your patient will tolerate non-invasive ventilation. However, if you don't go through the steps that we're going to talk about just now, it is very unlikely that the patient will tolerate NIV in the long term. So the first thing to do in a patient who's got a reasonable GCS, and you would expect a reasonable GCS to start non-invasive ventilation, is to explain the procedure to the patient. Take pains to make sure that your patient understands what you're telling them. Often these are elderly patients who've got reduced hearing, they are breathless, they are anxious, and they're not listening to what you're saying. So speaking to them and explaining the procedure is not a tick box exercise. You have to take the pains to explain the procedure to a patient in a manner in which they understand, and you can get the patient to repeat what you have said after you have done your explanations. Reassurance is important, and your reassurance with personal examples, with examples of other patients, generally is more useful. Important to place the patient in a semi-recumbent position. So your patient is normally on a bed which can be propped up. So propped up position with 30 to 45 degrees semi-recumbency is what is recommended. So there's a couple of things which is right on this slide and one which is wrong. What is wrong on this slide is the fact that the patient is not semi-recumbent. So that's not the position you put the patient on NIV. The patient should be propped up at 30 to 45 degree. The other thing to mention is that normally the nasal cannula should not be inserted. The nasal cannula should be on the mask on there. So you can see the doctor holding the mask in his hand. The oxygen should be connected in that mask. And the reason you don't want the nasal cannula is because if you put the mask on over the cannula, there might be a lot of leakage, air coming out from the sides, and hence your non-invasive ventilation on your BiPAP would be less effective. The second factor, which is very important, is to select an appropriate sized mask. I've seen people with small faces being given a mask which is too large, that comes beneath the neck with a prohibitive amount of leakage. So selection of an appropriate sized mask is important. Put the mask over the patient's face. You can hold it yourself. You can get the patient to hold it if the patient is comprehending what you're saying properly. Getting the patient to hold the mask gives the patient a sense of independence, gives the patient a sense of familiarity, and hence it's important to do so when there is an option to do this. If you're holding the mask over the face yourself, important not to apply a lot of pressure to start with, that puts the patient off. Important not to be in a hurry to strap it on. If you're teaching your nurses to do it, make sure that they hold the mask over the face for 3 to 4 minutes. Make sure that the patient is breathing properly before you apply pressure to tighten the mask over the face, and only then, maybe 5 minutes later, would you strap it on when the patient is familiar, confident with the concept of having the mask on. What sort of pressures do you initiate non-invasive ventilation? So start off at low pressures. It says 6 and 2 on there. This is from the BTS guidance. However, I suggest we start a little bit higher than that. So I suggest we start at about 8 by 4 or 10 by 4 and then gradually go up to a pressure that you think would be effective in that individual. The going up on the pressure should be gradual. The pressure that you want to achieve, you should achieve at the end of about half an hour of non-invasive ventilation rather than doing it in the first 5 to 10 minutes. It is only then that your patient will manage to tolerate non-invasive ventilation properly. I have said that the mask has ports to attach the oxygen to. It says attach oxygen at 2 liters per minute. You have to give enough oxygen to maintain saturations between 88 and 92%. However, with the BiPAP, you can only deliver about 5 liters of oxygen or no more than that. If you want to deliver more oxygen, you would require a non-invasive ventilation, which is the bigger machines, which can also give invasive mechanical ventilation. So an NIV for greater amount of oxygen, ward BiPAPs for where the oxygen requirement is less. And the aim is saturations of 88 to 92%. We have talked about how to hold the mask, how to familiarize the patient, how to make the patient confident. So I won't repeat this again. However, I'm happy for you to have these slides and think about these when you actually do it in your own intensive care unit, high dependency unit, or the ward. So this is holding the mask. You can see the doctor's hand holding the mask over the face. I've told you 2 mistakes on that slide. 1, the patient should be semi-recumbent. 2nd, the nasal cannula should not be fitted. It should be on the mask. The oxygen should be fitted on the mask itself. And while the patient position is wrong, you can see that the mask is nicely fitted. You can see the mask stops here at the chin. It doesn't go beneath. If it goes beneath, then there would be leakage and the tolerance would be poor. The effectivity of NIV would be less. So spontaneous mode on this BiPAP machine, it says 8 or 4. I've said you can do 8 and 4 or 10 and 4, depending on what the patient's body weight is. And then you increase the EPAP and the IPAP slowly. The IPAP goes up more, the EPAP goes up less, but the increase should be simultaneous. The difference, and this is important, the difference between the IPAP and the EPAP should be at least 4 centimeters of water. So that's not maximum, that's the minimum difference between the IPAP and the EPAP. If the patient is making an inspiratory effort and the ventilator is not responding to the inspiratory effort, it means that the patient does not have enough respiratory effort to counter the auto PEEP, which is triggering the ventilator, right? So important to understand that if the patient is not making enough of an effort, if the patient does not respond to the inspiratory effort, then you are not countering the auto PEEP that is being generated to trigger the ventilator. So here, increase the EPAP till the patient triggers all the respiratory efforts. At this, you have to look at the machine and understand this yourself. Keep this slide and do this in front of you when you have a patient and the machine together. So we have said this, increase IPAP and EPAP by increments of 2 centimeters of water. When the patient is triggering all the efforts and there's no upper airway obstruction, leave the EPAP at that level. And patients who are obese will normally require a higher EPAP of about 8. Patients who are lighter, patients who are thinner, you will get away with an EPAP of 4 to 6. We have said increase the IPAP after you've increased the EPAP, again by 2 centimeters till you reach the pressure that you're aiming for and the patient can tolerate without much discomfort, and there should not be many mouth leaks. And titrate the IPAP pressure to achieve a respiratory rate of less than 25 breaths per minute and a tidal volume of more than 6 ml per kg. So for a 50 kg man, you're aiming for a tidal volume of 300 ml. So these 2 numbers are important. In patients who would do well with non-invasive ventilation, the NIV or the BiPAP should bring the respiratory rate down to less than 25 and the tidal volume would be more than 6 ml per kg. So that's increasing the EPAP followed by increasing the IPAP. So initiation of non-invasive ventilation, we have said, check for air leaks. It's important not just to look at the machine, but also put your hand all around the mask, underneath. That's where most amount of leak is. If you've got a Riles tube in, if you've got a feeding tube in, obviously the risk is greater. If you've got nasal cannula going out, then the leak is greater. So put your hand all around the mask and make sure that there's no air leaking out from the sides, and hence you would minimize leak in these patients. Adjust the straps to make it tight, but not too tight. Tight enough to minimize leakage as far as possible, not tight enough that it goes into the face of the individual and erodes the skin surface and creates ulcers. So there's a fine balance which you will learn as you go along and keep putting patients on non-invasive ventilation. And this figure demonstrates how you go about doing that. The tolerance and acceptance of the mask and the pressure settings. So the degree of upper airway obstruction in individual patients results in the intrinsic PEEP that we spoke about a little while ago. You remember we spoke about increasing the EPAP. That's to overcome the intrinsic PEEP that's been generated. The success of an NIV, be that BiPAP or the conventional non-invasive ventilation, is only successful when the patient has got a good GCS. A patient with a GCS of less than 10, you should not go for non-invasive ventilation itself. So the respiratory drive during wakefulness and sleep is an important factor which determines the success of non-invasive ventilation. The ability of the patient to trigger the device, the difference between the IPAP and the EPAP, you remember we said a difference of at least 4 centimeters of water, and the amount of pressure support, all of these factors result in the tolerance and acceptance of non-invasive ventilation. The airflow resistance is important. The compliance of the respiratory system is important. How fibrotic the lung is, what sort of compliance the lung has is very important, especially in the post-COVID fibrosis era. And the inspiratory and expiratory time is also an important component. It's more important in invasive mechanical ventilation, but also important in non-invasive ventilation. So remember factors that's been mentioned on this slide. Important to remember them when you go near the machine. The degree of upper airway obstruction, respiratory drive during the wakeful and asleep stage, ability of the patient to trigger, IPAP-EPAP difference, airflow resistance, compliance of the respiratory system, and inspiratory time. We've spoken about oxygen supplementation during non-invasive ventilation. The flow rate, we said, would be determined more by saturations rather than being a fixed flow rate. It also depends on mask selection, it depends on leak, and it depends on the site. So whether it's been added to the mask, whether it's nasal cannula with mask on the top, or whether it's been connected to the tubing. Which one of these you do determines the amount of oxygen supplementation that you give during non-invasive ventilation. Humidification is important. Humidification is important for patient comfort, and it also helps in reducing the drying of secretions in the upper airway. However, you need to make sure that humidification does not interfere with the operation of the ventilator that you've given to your patient. So that's a nicely fitted nasal mask. What you saw a little while ago is the whole face mask, the full face mask. This is a nasal mask. You also have orofacial masks. The orofacial mask and the full face masks are what you would want in a patient who has got NIV under the acute scenario. The nasal mask you can do for home use in patients who are not mouth breathers. So that's a nasal mask. What about monitoring? The first thing you monitor is the subjective patient comfort. So how much comfortable the mask is for an individual. The tolerance of ventilator settings, IPAP of above 15 is often difficult for the patient to tolerate, especially in the acute scenario. And this results in tachypnea, this results in respiratory distress. Be persuasive with your patient. Stand there and talk to your patient and persuade them. However, do not tie their hands and their legs in trying to give them non-invasive ventilation, because the device is unlikely to be successful unless the patient manages to accept the device and the face mask they have on. The more you insist, the more in the patient's mind they would resist the device, and hence your intervention would be unsuccessful. The vital bed signs, the bedside signs to be monitored are easy ones. The respiratory rate, the heart rate, the blood pressure, use of accessory muscles, and correction of the abdominal paradox, the movement of the chest versus the abdomen, are things we have spoken about already. And these are factors that you monitor in trying to ensure that non-invasive ventilation is being successful. So the respiratory rate, the heart rate, the blood pressure, the use of accessory muscles, and abdominal paradox are factors to monitor. Alleviation of symptoms, we have talked about the symptoms. So alleviation of symptoms depend on what symptoms the patients had in the first place. If dyspnea was the indication, you would want the respiratory rate to come below 25, as we said. Hypersomnolence is what you're trying to correct in the acute setting, because there it's hypercapnia you're trying to correct. And in a patient who comes in moderately obtunded because of hypercarbia, it's improvement of the neurological status, which is what you're looking for. So that was the subjective symptoms, the individual symptoms. What about the ventilator parameters? So these are the ventilator parameters that you need to monitor: air leak, fit of the mask, adequacy of pressure support, so the IPAP and the EPAP levels. The PEEP comes along with that. Maintaining a tidal volume of about 6 ml per kg is what you look for, but a range of somewhere between 5 to 7 is important. And patient ventilator synchrony is important if the patient requires non-invasive ventilation for a significant period of time. That's ventilatory parameters. So patient parameters we spoke about, ventilator parameters we spoke about. Now we speak about adequate gas exchange. Adequate gas exchange is maintaining saturations between 88 to 92%, especially in the scenario of hypercarbic respiratory failure, type 2 respiratory failure. Arterial blood gas monitoring to look at the PF ratio and respiratory acidosis, again, if the patient has type 2 respiratory failure. And in some cases, larger centers can do CO2 monitoring, but this isn't compulsory. So CO2 monitoring, there's a choice. In the tertiary care center, if you have access, then please do use it, but it's not compulsory in centers where non-invasive ventilation is a niche use in patients in intensive care. So these are the factors which favor successful application. Where the secretions is less, where the patients have teeth, if there's no dentition, then the fit of the mask is poor and it becomes difficult because the face caves in and there is a lot of leakage. A lower Paget score, and we'll come back to this. The synchronization between the patient and the ventilator we've talked about. The Glasgow Coma Scale, the GCS we've talked about. If the patient does not have an appropriate Glasgow Coma Scale, the ability to protect the airway would be poor. A nursing and a doctor team which is dedicated in looking after these patients with non-invasive ventilation, they require as much of care as patients with invasive mechanical ventilation. And the response predictors, like we have said, is the pH, the PCO2, and the respiratory rate, and not mentioned here, but also the PF ratio. We have said close monitoring is important, but close monitoring is also important to make sure that if the patient is going downhill, if the carbon dioxide is rising, the respiratory rate is rising, the patient is becoming more acidotic, you can initiate endotracheal intubation early rather than waiting for the patient to crash and then initiating invasive mechanical ventilation where the chances of success would be low. So the goals we have talked about, but just to spell them out again: relief of symptoms, reduction of work of breathing, improving the arterial blood gas, optimizing patient comfort, good synchrony with the ventilator, minimizing risks, and avoiding intubation are the goals that I could think about for non-invasive ventilation. Those are the parameters you keep in mind when you start off with non-invasive ventilation. The long-term goals are improvement of the sleep rhythm. So this is talking about home NIV or home BiPAP, maximizing quality of life, improving functional status, and prolonging survival. So now that we have done the basic work, let's think about where in the respiratory system, the physiology of the respiratory system, by virtue of which this helps. So when we talk about the respiratory system, we talk about two different aspects. We talk about the lungs and we talk about the respiratory pump. The respiratory pump, I'll come to first, is what covers the lung. So you've got the chest wall with the ribs, the intercostal muscles, the spine maintaining adequate curvature. We talked about kyphoscoliosis briefly as being a cause for restrictive lung defect and hence hypercarbic respiratory failure. And if the respiratory pump fails, if there's ventilatory failure, so all the causes that we talked about, the kyphoscoliosis, the central hypoventilation, etc., the PaO2 goes down, the PaCO2 goes up. So respiratory pump failure results in hypercapnic respiratory failure. However, when there's lung failure, so when the alveolo-capillary membrane is defective, so think of interstitial lung disease, think of emphysema, think of areas where the alveoli are full. So when the alveoli are full with water, that's heart failure. When it's full of blood, it's diffuse alveolar hemorrhage. When it's pneumonia, it's full of pus. So all of these factors will result in a low PaO2 and a low PaCO2. And hence, this is type 1 respiratory failure or hypoxic non-hypercarbic respiratory failure. So we spoke about lung failure. We spoke about areas of lung being collapsed or areas of the lung full of secretions, alveolar filling diseases, consolidation, etc. Because gas exchange is defective, there's shunting. So the blood does not know that there's certain area of the lung which is malfunctioning. So the blood goes equally to the defective area, the consolidated area, the area which is full of blood, and that's wasted diffusion. So that's why this is called ventilation perfusion mismatch. This results in reduced diffusion through the areas which are defective and hence hypoxia with reduced oxygen delivery to various organs. We spoke about the lung becoming fibrotic. So interstitial lung disease being an example, COVID-19 being an example. So reduced compliance of the lung results in increased work of breathing, and increased work of breathing also results in reduced oxygen delivery. So with lung failure, talking about two parallel mechanisms. One is gas exchange failure and the other is reduced compliance of the lung. Hypoxia can also result in increased minute ventilation. So because you're hypoxic, the brain tells you to breathe faster, you breathe more number of times, hence there is more tachypnea. If there's more tachypnea, there's increased work of breathing. Increased work of breathing results in respiratory fatigue. And if there's respiratory fatigue, the muscles tire, the breathing muscles tire, and that's pump failure. So I want you to remember this algorithm of lung failure when we talk about hypoxic respiratory failure. And you understand that this pump failure can be due to pulmonary disease, but can also be due to cardiac disease, heart failure being an instance to the case. And I'll come back to this in a little while. So this is the entire plethora, the entire area of lung failure where ventilatory support, where you produce a volume, where you supply the patients with a volume of air along with the oxygen, comes in handy, comes in useful. Talked about COPD here and practice points. We'll discuss all of these in great detail later on. But I have put this slide in because this is the most important area where you would use non-invasive ventilation. And at least 7 out of 10 patients you put on NIV will have hypercarbic respiratory failure due to COPD. So all patients who come in with an acute exacerbation should have an ABG done. Find out whether the patient has that magic cutoff of 7.35, so below 7.35 pH with a PaCO2 which is above 50. NIV should ideally be started in a monitored bed, be that in intensive care or be that on a high dependency unit. However, I have a little while ago talked about scenarios where you can do ward BiPAP. The patient should be closely monitored in the first 1 to 2 hours. Make sure you repeat an ABG at the end of 1 to 2 hours. NIV should be given continuously in the first 24 hours, except when you're feeding, and then the process of weaning the patient off non-invasive ventilation, depending on parameters like saturation, ABG, etc., comes into operation. What about hypoxic non-hypercarbic respiratory failure? So these are patients who are generally tachypnic. They have a low PaCO2. So these patients will definitely need a full face mask and not the smaller nasal mask that I showed you a little while ago. The oxygen demand here is higher. So the bigger ICU ventilators is what you need rather than the ward BiPAPs on which these patients will be becoming more hypoxic. The pressure support and PEEP needs to be higher here with the fast rise time. The inspiratory flow needs to be high to compensate for air leak. And if the patient starts to worsen or continues to worsen, the threshold to transfer over to invasive mechanical ventilation should be low. These are patients where the degree of success is lower as compared to hypercapnic respiratory failure. We have said an ABG at 1 to 2 hours. If the PaCO2 is decreasing, if the pH is increasing, you've done well. Your patient is getting better. Consider at that point, post the 24 hours, to start reducing the duration of non-invasive ventilation. You can start giving them light diet, continue other medications orally. It's the first day and the first few hours which are the most labor intensive. Once the patient has the confidence to continue with NIV, once there's no asynchrony between the patient and the ventilator, your battle is more than 3/4 won. What about predictors for success? Who does well with non-invasive ventilation? So patients who have a younger age, who have less of illness as per the patie score, and I'll show you the patie score in a minute. Patients who can cooperate, who have a better neurological score, patients who can coordinate, synchronize with the ventilator, but there's less of air leak, dentition. If the patient has is edentulous and has dentures, try and put the dentures in and then fit the mask. It'll give you a better fit. Patients who have less severe hypercarbia and less severe acidemia, those are patients where non-invasive ventilation can be successful. An improvement of gas exchange, heart rate, respiratory rate should normally happen within 4 hours of setting up NIV. That's the patie score, and this is something that you can use, especially when you're starting off in clinical practice. This is freely available online, and this chart shows you, as you can see, the GCS and the pH, and the patie score is also in there. What's red is when you're failing with non-invasive ventilation. What's green is where you're succeeding with non-invasive ventilation, and the orange and the yellow is in between. I would ask you to use charts like this in trying to find out about risk failure, the risk of failure on NIV in COPD exacerbation. And what's invaluable for you is your technician, your nurse, your respiratory therapist, who are skillful enough, have all the skills that we talked about. You might have had to teach them it to them, but it's worth your time and worth your while to try and train people, get the right skillful people to deliver non-invasive ventilation, because that's what determines success and failure with non-invasive ventilation. So that's the basics. In the last 20 minutes, let me talk to you about various disease processes. We'll start off with COPD, and we'll go a little quickly here because most of the things I'm going to say are things that I have discussed already. So when we talk about acute hypercapnic respiratory failure, the BTS talks about in 3 categories. They talk about COPD, they talk about obesity, including obesity, hypoventilation, and OSA, and they talk about neuromuscular diseases. Today, I'm going to talk about COPD only, but remember, obesity, hypoventilation, and OSA exacerbations can also be an important cause of hypercapnia, and so can neuromuscular disease, which are rare but classically result in hypercapnic respiratory failure when they exacerbate. So this is what happens in patients with COPD. And I want you to see the 2 boxes on the 2 sides first. So COPD entails air trapping and hyperinflation. Hyperinflation results in flattening of the diaphragm. The diaphragm is stretched. More the stretching of the diaphragm, greater the degree of inflammation. More the inflammation, greater the systemic manifestations of COPD. The patients might be on steroids. The patients might have comorbidities like heart failure, pulmonary hypertension, etc. And then you have patients who are tachypnic and hence shortening of the inspiratory period, airways obstruction, increased ventilatory demands due to pulmonary failure, anemia and heart failure. All of these factors results in a reduced capacity of the respiratory muscles and increased load on the respiratory muscles. And this results in the breathlessness that you get in patients with COPD. This is mechanical ventilation for COPD, and you can see, irrespective of which study, and my cursor shows you the years of the study, so they are from lots of years ago, studies from 1989 till 1995, you can see a mortality rate of more than 40% in most cases, somewhere ballpark between 30 to 50%. This hasn't changed really, and that's why non-invasive ventilation is so important. You can avoid this mortality. You can avoid your patients going into invasive mechanical ventilation. So, invasive versus non-invasive. The rationale for non-invasive we've talked about, and I won't go through these numbers again. But remember, on non-invasive ventilation, clearance of secretions, communication, and swallowing are challenges that you have to remember in individual patients. The good aspects, the improvement of respiratory function we've discussed in detail, but remember, clearance of secretions, communication, the patient speaking to you, and swallowing are challenges with non-invasive ventilation. The rationale for NIV is easy. You avoid the complications related to non-invasive ventilation. The VAP, the local complications of tube, including the tracheal stenosis, etc., complications related to catheter, tracheostomy, weaning failure, all of these you tend to avoid by using non-invasive ventilation. So let's look at what the BTS guidelines tell you. So this is what we've done before. pH of less than 7.35, PaCO2 of more than 50 is what you're looking at, more than 6.5. Severe acidosis, however, does not preclude a trial of NIV. So even patients with a pH of less than 7.25, using non-invasive ventilation first, especially when acidosis is a result of hyperoxia, result of giving too much of oxygen, is something you can try in these patients. So NIV in acute hypercapnic failure, the level of evidence is highest with lots of RCTs in COPD exacerbation, in acute cardiogenic failure. A lot of patients with cardiogenic failure will have type 1 respiratory failure, the non-hypercapnic variety. However, some of them might have hypercapnic respiratory failure. Weaning and extubation failure in COPD are also important. So in my book, COPD exacerbation, weaning and post-extubation failure are top. Cardiogenic, even when you have raised CO2, it's worth trying non-invasive ventilation. The others, where it says medium and low evidence, we won't discuss. However, important to remember that even here, you should use non-invasive ventilation, but use it carefully. The number of patients who go from NIV to invasive mechanical ventilation in the low and medium evidence category is far greater as compared to the high evidence category. So that's the pH-based algorithm that we spoke about. pH of more than 7.35, no indication for NIV. pH of less than 7.20 plus multiple comorbidities. Intubation first is probably the way ahead. Whereas between 7.20 and 7.35, with isolated hypercapnic patient with a good GCS, NIV is the way forward, and you should always go for it. So once NIV starts, how do you actually monitor these patients? And we've spoken about all of this, but very quickly, the success of NIV is judged early on within the first 1 to 2 hours by repeating an ABG. And then in the long term, you gradually wean the patient from non-invasive ventilation and the patient comes to spontaneous breathing. NIV prevents intubation. NIV reduces mortality. And there's a huge number of meta-analyses which have actually looked at this and proven this. And it's beyond doubt that both of these factors, the reduction of mortality and the reduction of intubation, is something that non-invasive ventilation has done very effectively. So what about NIV versus conventional ventilation to treat hypercapnic failure? You can see here the endpoint that we're looking at is patients who are unweaned from mechanical ventilation. And you can see NIV here and the conventional mechanical ventilation at the top. And you can see that the numbers are similar. However, the complications are far lower with non-invasive ventilation as compared to invasive mechanical ventilation. The reason that NIV fails, and again, this is something we have spoken about before, is ineffective ventilation and failure of synchrony. And hence, this results in NIV failure. The NIV failure rates are greatest early on. So the green bit here on the circle is early failure within 2 hours, and that's 68%. That's why yourself and your experienced medical staff who is monitoring NIV early will ensure the success of non-invasive ventilation. And then you have the 17%, which is late failure, and the 15%, which is early late failure. So a small amount of patients fail within 1 hour. The next bit of patients normally fail within 1 to 2 hours. Some say up to 48 hours. And again, a small percentage of people will fail NIV after 48 hours. In my personal experience, after 48 hours is probably even less than 17%. So what are the causes of early NIV failure? So early failure is dependent on comorbidity and acute decompensation. So the variables that you have here are on this chart, the variables associated with non-invasive ventilation failure early on, and they are on this chart. I won't dwell on these and go through these in greater detail, but these include progressive disease, multiple comorbidities, presence of a pneumonia, presence of cardiogenic pulmonary edema. So all of these factors will result in early failure of non-invasive ventilation. But I want you to remember this bottom line. The higher the number of comorbidities, the greater the chances of failure. What about intubation after NIV failure in COPD? The risk factors in the emergency are 2 that I want you to remember. A GCS which is below 15 and age which is above 65 are the strongest factors for NIV failure in the emergency department. What about mortality? So mortality outcomes of non-invasive ventilation for acute exacerbation of COPD are good. You can see the NIV success on there, the blue circles on there, and the mortality rate you can see is far lower, somewhere between 10 to 15%. At the top on there, you see patients who are not on non-invasive ventilation, the patients who've been transferred to invasive mechanical ventilation, and here the mortality is far greater. So non-invasive ventilation to invasive mechanical ventilation is a continuum. It's not a fight between NIV and invasive mechanical ventilation. It's patients being managed with non-invasive ventilation. Most patients succeeding if they are done in the right way and for the right indication. And then in a small minority of patients going on to invasive mechanical ventilation when non-invasive ventilation is deemed to have failed. So the use of NIV should not delay escalation to invasive mechanical ventilation. And again, without reading through this table, these are the indications of invasive mechanical ventilation. The indications on there, I would argue, are late in the course, and maybe invasive mechanical ventilation should actually be earlier than what's actually depicted on this thorax paper from 2016. What about late failure? So for late failure, the important factors are so ICU mortality 92% when NIV was continued and 53% when intubation was performed is what you see on that slide. And like I said, I was coming to risk factors for late failure. So pre-treatment high Apache score, raised CRP indicating high inflammatory load, poor sensorium with a low GCS, asynchrony between the patient and non-invasive ventilation, a patient who has got a bad cough because of bronchiectasis and pneumonia, and absence of improvement of the PF ratio are important factors for late failure of non-invasive ventilation. And I want you to remember these points going forward so that you recognize late failure in your patients with hypercapnic failure. The other indications we said it's worth remembering, but not in the ambit of this talk: obesity and neuromuscular disease. Neuromuscular disease, interestingly, is the indication for which NIV was started, and NIV should almost always be trialed first in a patient who's acutely unwell with neuromuscular disease and hypercapnic respiratory failure. And again, the success in patients with obesity hypoventilation is also very high. So this is looking at acute lung injury and non-invasive ventilation, and you can see the reduction of intubation, reduction of mortality that we spoke about in this meta-analysis, which has come from our country, from Ritesh Agarwal's group in PGI Chandigarh. So this is patients who have ALI, so acute lung injury. Here we are talking about type 1 respiratory failure. And while there's reduction of non-invasive ventilation, the number of patients who avoid non-invasive mechanical ventilation is far lower. So intubation is avoided in less than 50% of cases, and mortality is avoided in a third of cases. So a lot of patients with acute lung injury and type 1 respiratory failure end up being on invasive mechanical ventilation. This is more of the same. So for the want of time, let me go forward. So this is looking at type 1 respiratory failure, acute respiratory failure, and the level of indications for these. And these are indications where non-invasive ventilation is the best use. So the red arrows are the ones I want you to remember as recommendations for NIV treatment where the evidence is at its maximum. So immunosuppressed patients, especially because in this category of patients, the chances of secondary infection with invasive mechanical ventilation is the greatest. Post-operative respiratory failure, severe community-acquired pneumonia, chest trauma, and IPF is where the most amount of evidence is in hypoxic respiratory failure, which is not as a result of heart failure. So non-cardiogenic pulmonary edema. So immunosuppressed patient, post-op respiratory failure, severe community-acquired pneumonia, thoracic trauma, and a small niche area of IPF that I will talk about in a minute. So there's also indication. So our patients in intensive care, we sometimes put them on non-invasive ventilation through a mask, which has got a port to introduce a bronchoscope. And that's what you see on this slide. That's us putting on a mask through which you can introduce the bronchoscope. This is to facilitate interventional procedures in hypoxic patients who are at high risk. Patients with IPF and acute respiratory failure, there are several studies, small studies, but several studies on this. This is mainly from an ethical standpoint. You do not want to ventilate patients with end-stage respiratory failure where the underlying diagnosis is IPF or any cause of progressive interstitial lung disease, end-stage interstitial lung disease. And in these patients, if the patient comes into intensive care with respiratory failure, you would want them to go on to non-invasive ventilation. The only reason for invasive mechanical ventilation would be as a bridge to transplantation, and hence these papers are important to remember. So these are areas where NIV can be used, palliation being one, while you're excluding treatable causes, and like we said, invasive mechanical ventilation or non-invasive ventilation as a bridge to transplant. In the last 5 minutes, I'll talk to you about the last two indications, important indications, NIV in cardiogenic pulmonary edema. So NIV in cardiogenic pulmonary edema is for improvement of oxygenation and improvement of respiratory acidosis, reducing the work of breathing, improving the cardiac contractility and hence cardiac performance, and reduction of respiratory distress in your patients. You start off with CPAP, The FiO2 requirement is generally high. You would want a full face mask in these patients. And the peak, like we said, is set at about 8 to 10 in these patients. The inspiratory pressure does not need to be very high. Somewhere between 14 to 20 is what you're aiming for. With CPAP, there's more of distribution of blood flow into the intravascular compartment. The seepage of fluid from the pulmonary capillaries into the alveoli becomes lesser, and hence spontaneous breathing becomes easier in these individuals. There are multiple studies in heart failure. I show you one of them where 18 patients were on standard treatment plus oxygen via nasal cannula, and 19 patients were on standard treatment with NIV and oxygen. And the patients on NIV started resaturating. Their saturations went up much earlier as compared to patients who had oxygen cannulas on. In the group who were on standard treatment with plus oxygen with a nasal cannula, 6 patients got intubated, and the resolution of heart failure took about 105 minutes. In the other arm, when used NIV with oxygen, 1 patient got intubated, and the resolution time for heart failure came down from 105 minutes to 30 minutes. So amazing results, at least in the short term, with NIV in cardiogenic pulmonary edema. These are other trials, and I'll leave these slides with you to go through. But again, they show the use of non-invasive ventilation in cardiogenic pulmonary edema. So this is an American Journal of Respiratory Medicine paper, 130 patients, 65 allocated to medical treatment, 65 to non-invasive ventilation. And you can see out of the 65 on medical treatment, 49 were treated successfully and all 49 survived. In the 16 intubated, only 7 survived and 9 died. In patients on non-invasive ventilation, 13 got intubated and 7 survived. 52 were treated successfully and hence all of them survived. So that's the comparison. So similar intubation rate in both arms. However, patients who received NIV in this study had significantly better improvement of the PF ratio in the first 30 minutes, like we showed in the previous study also. And hence, again, this Cochrane review, which looked at non-invasive ventilation in the form of CPAP or bilevel non-invasive ventilation for cardiogenic pulmonary edema, you can see that there's improvement, reduction in endotracheal intubation with the use of non-invasive ventilation. The last bit without which this talk would be incomplete is NIV in COVID-19 infections. So the WHO guidance on NIV in COVID-19 gives a cautious recommendation that high flow oxygen in the form of HFNO and NIV may be useful in select patients. Viral filters are recommended for NIV, and this is mainly for aerosol generation and the risk to other patients and healthcare workers. NIV might also play a role if ventilators and ICU beds are unavailable, and HFNO or NIV should be used only in select patients with hypoxic respiratory failure. These are the Chinese guidelines, and again, I have outlined this for you guys to have a look at. High flow nasal oxygen or NIV when respiratory distress and or hypoxia of the patient cannot be alleviated after receiving standard oxygen therapy. HFNO or NIV might be used. And this is from JAMA Network, and there are other guidance. This is the Sublime Sepsis guidelines, and like I said, go through these slides because they tell you the importance of NIV and HFNO in COVID-19 cohort of patients. This is the BTS guidance, which I think is the best we have as far as use of NIV and HFNO in patients with COVID-19 infections. We have talked about fitting of the masks. Here it is very important. Well-fitting oronasal masks. Vented masks should be avoided. Any patient on acute NIV should be managed with a non-vented mask. Ensure that the ventilatory mode employed supports non-vented masks. And the way to put it on is to put the mask on and then switch the ventilator on. And when you're taking it off, what you do is to first switch the ventilator off and then take the mask off. So do it in such a way that you minimize aerosol production as far as possible. The importance of filter is important, and let me show you a picture that's better. So that's the picture So there are three parts that we talk about. This is the face mask, which is to be fitted well. That's the filter that we talk about. And this is the exhalation port. And the sequence in which you do it is that's the non-vented mask. And you should have a ventilator which accommodates this non-vented mask. You then have the bacterial or the viral filter. And post the filter, you have the exhalation port and the connecting tube. So that's the sequence to have it. It should not be a vented mask is the most important factor to remember. And when do you use it? If your respiratory rate is around 20 and your saturations are less than 94, you go for oxygen. When your respiratory rate is above 20 and the saturations are below 94 on oxygen, which is more than 40%, you need to think about using non-invasive ventilation or NIV in these patients. And then the red box below, as always, is the very poorly patient who cannot maintain saturations even with an NRBM, and there critical care review and intubation and ventilation is important. This gives you a flow diagram of how to actually escalate treatment for patients who are COVID positive in intensive care, and it has got the CPAP and the NIV arm in it. But I leave that slide with you guys for you to look through in your time and think about your management of COVID-19 patients. So I'll finish off there. I think I've just about touched 1 hour. I hope you did not find that talk too lengthy, and I hope you find it useful in your clinical practice. I'm hopeful that CCI will provide you with this talk so that you can listen to it in small parts and try and use it in your day-to-day clinical practice. Non-invasive ventilation is something that you cannot do without, irrespective of where you practice today, whether it's a tertiary care center or a primary healthcare center. Non-invasive ventilation in patients who are in a monitored bed is a must today. Try and do it with patience. Try and do it with prudence. Train people to do it with you. Your technician, your respiratory nurse are a must if you want to do non-invasive ventilation well. I wish you all the very best. I would be happy to take questions, and hopefully I'll meet you again at some point of time on this CCI platform in the not so distant future. Thank you very much and take care.
Okay. So I believe that sorts out most of our questions on non-invasive ventilation. And I should assume that there will be very few questions after that completely lucid kind of a lecture from sir as usual. In fact, it polished off all of my NIV data and my whatever, has been my study of NIV. So I thank you, sir, for this brilliant dwell on the NIV and acute respiratory failure. Though it's a huge topic and you covered it really well in this 1 hour, which has been in the past 1 hour, must have been a lot of learning for everybody. So now let's go straight to the questions. And we have a question from Dr. Umesh Prasad, who from Devgarh, who asks about what should be the treatment for acute respiratory patient in a clinic. Now, sir, it all depends. I'll answer a few things and then I think I should hand over to Dr. Dar. So in a clinic, it depends on what all facility you have in the clinic. My general advice or, thinking when people ask us that, how do you manage acute things in your clinic is please do not attempt to waste further time in the clinic and shift the patient to a tertiary place where things can be done in time as soon as possible. Your take on this, sir?
So agreed, Vaishali, couldn't agree more. I think if you're talking about an OPD clinic, you would not be expected to have non-invasive ventilation in an outpatient-based clinic. You would need inpatient services, you would need a bed, and you would need a monitor to do non-invasive ventilation. That's the least that you would need. So like Vaishali said, I think what you need to do is to send off to the nearest and safest place where you can for non-invasive ventilation initiation. What you could do in a clinic, Vaishali, and I think you would agree with me, is to do home NIV services. So if you have people who've got bad COPD with hypercapnia or an OSA patient, you could actually have NIV for demonstration in your clinic to show patients exactly how it is done. But that's more for home NIV rather than acute care NIV, which is what we are talking about today.
Right, sir.
Sir, there is a surprise host joining in the session.
Can I go over to the next question? I think so. Okay. So the next question is from Dr. Shantini from Chennai as to how to decide if the HFNO is not appropriate for the patient. So appropriate, yes, but how it is not appropriate for the patient. So generally what I feel is if the patient has a high respiratory rate, so the work of breathing is really high, I personally prefer to go in for an NIV over an HFNO. Okay, and it also depends upon the patient's acceptance. So first you're doing a counseling, and as sir has rightly mentioned in his slide, that you keep the NIV mask on the patient's face for some time before strapping it on, and keep on assuring the patient. And if you find that there's a comfort level, I have seen some patients, the moment you put the mask on their face, they just try to throw it away, they try to get out of the bed. In such cases, I think an HFNO would be more appropriate unless you're requiring an invasive ventilation. But not appropriate is a person who has severe respiratory distress in terms of their work of breathing. So the happy hypoxics do really well with HFNO who are not doing, require something more than the regular oxygen therapy. But if you have a patient whose respiratory rate is high, then HFNO should not be appropriate. Your take, sir.
So agreed, Vushali, again, agreed on all points. The only thing I would like to add is the high flow nasal oxygen data is actually with acute respiratory failure, which is of the type 1 variety. So it's about hypoxic respiratory failure without the hypercapnia, where most of the data is. There are trials also about hypercapnic respiratory failure, the type 2 respiratory failure, but that's emerging data. And I would recommend that for hypercapnic respiratory failure, it should always be, or in most cases, be non-invasive ventilation. Like Vrishali said, it's the patients who are just hypoxic, are not hypercapnic, where you would think about HFNO up front, and it's a modality, it's a gadget which patients tolerate much better, as Vrishali said, as compared to what non-invasive ventilation does. However, with HFNO, you can probably give a maximum of about 60% oxygen max. You can push it up to 70 and 80, but you don't really deliver that in the real world. And if you're needing higher than 60% again, you probably are better off with non-invasive ventilation and thinking about invasive mechanical ventilation, because then you're going to prohibitive levels where even with NIV, you might not be able to maintain oxygenation the way you want to.
And also, there's this data in which it says that HFNO should not be really put upfront, considered for patients who have got cardiogenic pulmonary edema. So there, though it has a driving PEEP, some amount of PEEP it does achieve, but still not recommended in cardiogenic pulmonary edema, though it's a hypoxic respiratory failure. Okay, now this question, sir, you'll have to take
So
yours.
We've got Dr. Krishnan here, so we might as well greet him. So thank you for coming in, Dr. Krishnan. Absolutely delighted. I can't see you. I can see a lovely photograph.
Just
I can't
one
see
second, one second.
The smiling face.
Indeed.
One second.
The smiling handsome face. It's not just the smiling face, Vishali, isn't it?
So touched. One second. I'm joining. You guys keep ahead.
While Dr. Krishnan is joining, Vrishali, just to add, the PEEP that you achieve with HFNO is never going to be the same as the PEEP that you would achieve with non-invasive ventilation. So completely like Vrishali said, I think that's a learning point which needs to be repeated, that HFNO is not where you want to recruit alveoli. So be that in patients with diffuse alveolar hemorrhage, be that in patients who have got heart failure, cardiogenic pulmonary edema, the way forward, there's not much of data with HFNO. It's mainly data with non-invasive ventilation. Whereas it's patients with a pure acute respiratory failure, the COVID-19, for instance, where you get hypoxic respiratory failure, where for all of us, HFNO has been a boon in treating patients. Good to see you.
Yeah, hello. I'll just take 2 minutes.
Hello, sir. Good evening.
I've reached my Vrishali. Hi, Vrishali Behan. Hi, Raja Bhai. I have breached my protocol today. I have never ever come like this. Okay. So the reason that I breached the protocol is that I want to announce to the entire nation today Rajadar's WhatsApp number. He's not on WhatsApp. He's telling, but I'm announcing to the entire nation today his WhatsApp number, mobile number. Okay? No, don't worry. He's not on WhatsApp. I'm pulling his leg. Okay. So let me be just 2 minutes. I'll take. Raja Bhai, it was absolutely brilliant, and we had 1,147 logins today. And CC is known for logins that we come around 1,000 always. Okay. But I still feel that having you over here and Vrishali Behan here, you guys were brilliant. Come on, that's it. But still, I would go ahead admitting that having 3,000 reach of CCI, our logins of 1,000 around are like Tendulkar scoring 13 every match. So come on, CCI guys, next time onwards, we'll be having somewhere around 2,500, 3,000 logins. So thank you so much. And I interrupted breaching my protocol today because, you know, at times when I felt for the first time, it was going great. And Raja Bhai, you were stupendous. No more words. And Rushali, she's talented.
Fantabulous, fantastic. There is this, dance thing where this lady uses those words. I'm sorry, I don't recall.
Yeah, definitely. And Rushali, she's there here. She's a multi-talented cultural girl. Raja, are you aware of that?
I do. I know.
Yeah,
I'm
multi-talented.
the nightingale of the CCI. So I was just telling
her.
Yes, absolutely.
Yes.
So I was just going to say,
So,
Dr. Krishnan, so I have said this to you informally, but I'll say this formally. I think the nation needs to thank you. The respiratory physicians need to thank you and the CCI team for the job that you're doing in presenting young talent, people like Vrishali, and there's multiple others who have a face today, who can present in front of a national audience today for what CCI is doing. So well done. Kudos to you and the entire team. Really, really privileged to be a part of this team. Thank you.
I have unhappy news for you too, but a happy news for the entire audience. I am allowing this session to continue till 10 p.m.
Right.
Because there are plenty of questions. Unhappy for you guys, but happy for our CCA family. All set? Bye-bye.
As Dr. Dhar said, I couldn't agree more. We have got this platform thanks to CCI, and I think this is one of the WhatsApp group which I never delete. I keep on reading through it because it's an amazing academic group. And yeah, in addition to the academics, I am absolutely happy with the other non-academic for things which are presented, but it comes with the academics. So it is one of the most brilliant groups that I have come across, and I really am privileged to be part of this group. Thank you so much. Thanks for the
salutes. Bye-bye. Carry on. I'm leaving.
Yes.
Bye-bye.
Okay. Good day, sir. Night. Bye. Okay. So we come to our next question by Abhijit from Rengari, Sambalpur. That can we have this non-invasive ventilation at, can we do it at peripheral centers? So my take on that is, sir, if you can train a good respiratory nurse or, you have a technician. Nowadays, even I can vouch that one of my technicians who is actually not even qualified, a 12th standard pass kind of a guy. We train him in bronchoscopy, and I can assure you that the guy knows when we are inside the segment, when it's going to bleed, when I need next forceps, what. So if you can have that kind of a person and your training, you can achieve, have a non-invasive ventilator at a peripheral center. But again, where you have a backup of invasive ventilation, because the most important part in a non-invasive ventilation, I believe, and it is, which is there everywhere, is that if there is a delay, you tend to rely too much on the NIV and wait, then it can be a problem for us, and by not initiating the invasive ventilation within time. So a peripheral center depends on how peripheral you are. So availability of the machines, if you can have a couple of machines, I think it will do enormous kind of a good for the people who are there at a faraway place. Especially if it's some kind of a transport machine also, where you can transport an individual in the same, on the same ventilator.
Lovely answer. Yes, lovely answer, Vrishali. I like the way you talked about the scope for invasive mechanical ventilation. So not only for peripheral centers, not only can you have a non-invasive ventilator, you should actually have BiPAPs. So I recommend that you have BiPAPs rather than having the big NIV ventilators that I spoke about in the talk, and Vrishali just alluded to it. Do have them, but then make sure you know that a center which is not far away where you could transfer the patient reasonably early in case the patient gets worse. So if you've got intensive care where you can invasively ventilate patient, of course you'll have an IV. I mean, that's a no-brainer. But if you don't, which is I think what this question is about, make sure you have the logistics ready, you have the transport ventilator ready to make sure you can transport the patient to a place of safety in a short period of time. The bridge time should be as short as is feasible. But do have it in your peripheral centers. That's the whole point of having non-invasive ventilation.
Absolutely. And I think, many of our patients, sometimes like you have a cardiogenic pulmonary edema or some other reason where a small ventilation, non-invasive ventilation ensures that the patient tides over a crisis and avoids an invasive ventilation. So absolutely makes good add if you know the know-hows of using the non-invasive ventilation.
And not just with cardiogenic pulmonary edema, Vrushali, not just with cardiogenic pulmonary edema, but your patients with AECOPD, which is your biggest lot. If you manage to start NIV in that pH gap between 7.30 and 7.35, 90% of your patients will actually not need transfer to a center which have invasive mechanical ventilation. You would manage to actually tide them over. But that's the golden bridge, 7.30 to 7.35. Start your NIV early. The results would be great. Sorry, Vrushali. Next question.
Okay. So this you'll have to take because I'm absolutely not aware of this. This is from Nani Gopal Ray from Kolkata. So is there any role of inhalation of surfactant in COVID-19 infection with respiratory distress?
So I don't think that's actually a NIV question.
NIV related question, but I thought as well. If,
but I think no, absolutely. So I think fair point. Yeah, absolutely. So there is a couple of trials which are ongoing. I think this is actually from an India Today article which came out about 10 days ago, where Oxford is trialing surfactant in patients with non-invasive with COVID-19, and the aim is to prevent mild ARDS from progressing to moderate and severe ARDS. That's what the trial is. So it has a PF ratio, a PaO2 FiO2 ratio of somewhere between 250 to 300 as an inclusion criteria in COVID-19. If your PF ratio is in that range, surfactant in the form of nebulized drug is given over a period of 10 minutes. I forget the dose, I'm sorry, but it's to try and reduce the compliance of the lung and try and increase the tidal volume in these patients. It's an ongoing trial. It's a phase 2 trial. The animal trials have been completed. I don't think we have got results as yet. So it's an emerging therapy area in ARDS. A same thing has been extrapolated in patients with COVID-19 who have an ARDS-like phenomenon with severe COVID.
Okay, so I put in a comment for the audience that that sir can answer any questions. You are welcome to put out questions even which are without non-invasive ventilation. Right, sir? Because we've got time till 10 o'clock.
Dr. Krishnan has left. So I think we'll sort of finish at about 10 to 10 if that's okay.
Absolutely, sir. Okay. Okay, so Dr. Ramesh Rao from Bengaluru asked about, is there any early clinical or biochemical markers for respiratory failure? Okay, so you'll have to take this question.
Yeah. So
clinical
I think
we have.
So clinical there are plenty. So clinical we just spoke about, mild, moderate and severe ARDS is classed according to the PF ratio and also appearances in CT imaging. So that's how you class mild, moderate and severe ARDS. There are certain, so CCL6 for instance is a marker for mild ARDS, which is a biochemical marker, but it's a research biomarker. I don't think we have biomarkers which are in clinical use today, which would actually diagnose ARDS or classify them into mild, moderate and severe as yet. I think the best way to do it is with the PF ratio. And I know there's a lot of young audience today. PF ratio is easy to do. Remember that, right? So if you have someone who has, for instance, is on an FiO2 of 40% and you've done an ABG on that individual and you find on the ABG, the PaO2 is 60. So I'm giving you an inane simple example. But so PaO2 of 60, FiO2 of 40. So that's 60 by 40 into 100, right? So it's easy to do. So 60 by 40 is 3 by 2. 3 by 2 into 100, which is 33 into 50, which is 150. So the PF ratio there is 150. So start documenting this in your file. You will know what's mild ARDS, what's moderate ARDS, what is severe ARDS. And this, by the Berlin criteria, is actually robust. And if you start doing this, get into the habit of doing it, you know when to initiate what. You don't want to be giving NIV in patients who've got type 1 respiratory failure with a PF ratio of less than 100. That's the patient who needs intubation and ventilation. So doing the PF ratio also gives you the management plan going forward. Biochemical markers, we've not got there, and maybe it's not necessary at the moment to have biomarkers, blood biomarkers, to talk about ARDS.
On that note, I will even like to say that when you have a patient who's on oxygen, how do you calculate the FiO2? So it is a 1 liter of oxygen that is equivalent to 4%. So if you have a 21% in the inspired room air, so you give the patient 1 liter, that means your 21 plus 4, the FiO2 is 25% and so on. So you can do a PF ratio even for individuals who are on oxygen, right? Okay.
Absolutely. Very good. Yeah.
Now, the other question from Dr. Rao is again, how to know respiratory failure is impending? I think that question has been covered adequately in Sir's talk. And Dr. Nagaraja from Madanapalle, he says that which stage NIV is indicated, how clinically we should know. I think we just dwelt on it, sir, in the last question. Yeah. So you want to add something to it?
No, I think we'll go ahead. There's plenty of questions.
There's plenty. Okay. Now this question comes from Dr. Anchal. A few of them are saying, thank you, beautiful lecture, excellent lecture, very crisp, nice clarity of the basics. So thank you for that. And there's Dr. Archil from Dattapura, who's asking us that in the case of acute appendicitis or intestinal perforation, where a surgery is not done, should we give NIV support? So I will give my couple of takes in this. So this was a problem which we faced for a lot of patients who've gone upper abdominal surgery, especially gastric bypass, esophageal perforation, where a surgery has also been done and where the surgeon is quite worried that, you know, your NIV should not give rise to the giveaway of the anastomotic sutures. So generally the lower esophageal pressure, to breach that, we have to go with the IPAP level, which is the 25 centimeters of water is the pressure which is required to breach that. And we generally do not require that kind of pressure support or IPAP on an NIV. So we can give such individuals NIV, and particularly, madam, when you say that is acute appendicitis or intestinal perforation, I believe there will be an RT in situ. So you can aspirate the extra air which is inside, and I think it should be done and very well can be done. So
couple of things, Vrushali, very, very good points I think you brought up. So sort of as a corollary going around, I don't have anything to add to what you've said as a direct answer to that question, but a couple of things important that you brought up for the audience. If you have someone who's stuck on non-invasive ventilation for long periods of time, it's important to have an NG down. Like Vrushali said, the reason you should have an NG down is twofold. The first is, if you keep giving non-invasive ventilation with a full face mask or an orofacial mask to patients, you will end up having some degree of gastric distension in these patients irrespective. And when you have gastric distension, your diaphragm goes up, you splint your diaphragm, the lung gets squashed, and the breathing becomes more labored and patients become tachypnic. So not just in the acute appendicitis scenario where it's very relevant what Vrushali said, but even in patients where you're not managing to take the mask off, because taking the mask off means that the patient desaturates, it's important to have a Ryle's tube, a feeding tube in. When you're putting the feeding tube in, it's important to put it right, because the feeding tube almost definitely will increase the amount of leakage there is. So make sure that you fit it in properly and try and minimize leakage as far as possible. The other thing is, so you talked about a scenario, the question talked about a scenario where there's acute appendicitis, acute cholecystitis, where the patient is not been operated on. Along with that, think about a scenario where the patient has had a surgery and now needs weaning off with non-invasive ventilation. Even there, even though you've got sutures in place, you've got clips in place, giving non-invasive ventilation is actually a good idea, because it helps you to wean the patient off gradually rather than ending up ventilating the patient again. So NIV in the pressures that Vrushali spoke about, lower pressures, so a pressure of 12/6, for instance, or a pressure of 14/6 or 18/6, which is normally the maximum you need in these scenarios, is an essential prerequisite, something that you should do if the patient has an indication of non-invasive ventilation, because you save the patient going into invasive mechanical ventilation in these scenarios.
Okay. So Dr. Tadip Chatterjee sir asks from Mumbai that how do you select the different modes of NIV? That is, when do you decide on a CPAP, when do you decide on a BiPAP, and the different conditions that both for type 1 and type 2 respiratory failure.
Sorry,
yes,
you go on first. Shall you first? No, you first. Go on. Sorry.
No, sir, you first.
Okay.
So, sir, please go on. Yeah, I am.
So I think, you go have a go second, Vrushali, because we are both speaking together. So I think the CPAP is without exception for your patients with heart failure, right? So cardiogenic pulmonary edema, CPAP would be the modality of choice. I would start off with a high PEEP. So your CPAP pressures would be slightly on the higher side, because what you want is for the fluid to return to the intravascular compartment. So you're trying to squeeze the lung, get the fluid out of the alveoli into the intravascular compartment, and hence you're increasing the PF ratio in these individuals. In others, almost entirely, it's going to be BiPAP, especially in your patients with type 2 respiratory failure, in your patients with hypercapnic respiratory failure. And it's actually the difference between the IPAP and the EPAP which helps to push down the carbon dioxide in these individuals. So that's something worth remembering. In your patients with hypoxic respiratory failure from other causes other than cardiogenic pulmonary edema, I think you again opt for BiPAP or NIV, because even here it's both the pressure and the pressure difference between the IPAP and the EPAP which helps in alveolar recruitment in these individuals. So that's my take, Vrushali. Let's hear what you have to add to that.
Sir, absolutely, as sir said, I have nothing else to say, because sir has said the necessary things. That your CPAP it's proven only in a cardiogenic pulmonary edema. Rest all of the conditions you require the difference between the IPAP and the EPAP for us to achieve the ventilation. So all your COPD, neuromuscular diseases, your central hypoventilation, you require an IPAP, you require a BiPAP for these patients. So now sir spoke about the minimum difference between the IPAP and the EPAP, which was 4. That is what you have to mention. So there's a question from Dr. Yashin Lucknow, that what is the maximum difference that can be achieved or should be achieved between the IPAP and the EPAP?
Sure. So I don't think there is a maximum actually. So you know, it depends on how bad the hypercapnia is, how high the carbon dioxide is, and like we said just now, it's the difference between the IPAP and the EPAP which helps to drive the carbon dioxide out of the system. So if you think about one, so I'll give you an example which will help you to understand this better. You know, when you talk about home ventilation in patients with hypercapnic respiratory failure, so patients who have got a perennially raised carbon dioxide, the improvement in mortality in these individuals with home ventilation depends on how high you can push up the IPAP in these individuals. So there have been lots of German studies which have looked at IPAPs of as high as 26 to 30. And the EPAP remains at about 8 to 10 in these individuals. It's the Germans who can tolerate these high pressures. I don't think us Indians can tolerate pressures as high as that. But that's just to say that you can have huge differences between IPAP and EPAP in trying to drive down the carbon dioxide, where the end point is trying to reduce carbon dioxide to improve mortality in these individuals.
So, and the same setting, since we had the last question on the presence of, putting in an NGT, there's this question I believe is answered for Suryashil from Vijayawada, who says how to take care of a patient feeding if a patient is becoming hypoxic even after short periods of mask removal. So, sir has already pointed out that where you have these patients who are going to re-recruit or are going to become hypoxic, you have to have an NG tube in situ for the feeding. Do not remove the NIV in such cases. Otherwise, we come back to where we went, where we started from. every time the NIV mask is disconnected, the patient is going to go back to his original status. Now, we have a lovely question from Dr. Vijay Kumar from Chanam Chetty from Hyderabad. That is, how do you take it, pneumothorax and NIV? So I believe what you want to ask is that if you have a patient of pneumothorax who's tachypnic and NIV, and you have no facility for ICD and no facility to intubate such an individual. Well, so what I think is we give high flow of oxygen, and I think even if there's no ICD facility, what one everywhere can have is a big bore needle. Okay. And in such a condition, we can put in a big bore needle and connect it to an underwater seal. And if that, while putting the patient on a high flow oxygen, if that doesn't settle it, yes, then NIV can be inserted in. I'm not sure in this case, as we were discussing, whether we go on low on the pressures, which I believe that the patient is not going to require a high inspiratory pressure in such condition. So yes, you can manage pneumothorax if the NIV is needed without an ICD and there's no facility to intubate. But you cannot predict, and you try your best. So it is like asking in the last slide somewhere that in a clinic setting, how do you address an acute respiratory failure with what ventilation? So my take is that you put in a large bore needle connected to underwater seal and just give it some time for the patient to expand. So a little more coherent than what I did.
Yeah, I think you're very coherent. I mean, I don't think Vijay would be actually speaking about a situation where there is no facility to put in an ICD. I think there'll be very, very few places where I hope there is no facility to put in an intercostal drain or a pigtail or a hook drain or a Romson drain. I think most centers should have the training to put in a chest drain, because for a pneumothorax, and I guess we're not talking about a very small pneumothorax here, we are talking about a pneumothorax which causes respiratory compromise. You will not get anywhere without a chest drain. So if you don't know how to put it, you will need to get someone who will put it for you. And the non-invasive ventilation will not be solution for pneumothorax. The intercostal drain will be the solution for the pneumothorax. And once you have put...
He is saying there's no facility for ICD placement. So there's
that's what I'm
ICD.
saying. So I'm not sure whether we should have a facility. Bushali, what I'm saying is that for a pneumothorax, you should have a facility which has where you can put in a drain. I don't think the NIV can be a replacement for a chest drain in someone with a pneumothorax. That's what I'm saying. So if there is no facility, you should have a facility to put in a drain. And putting in a drain is no big deal. It's something that most centers should be able to do. I think what Vijay might be asking, so I know Vijay well, so thank you for that question, but I think what he might be asking is, so, with COVID, one of the things that we have faced is a lot of these patients with fibrotic underlying lung are getting pneumothoraces. And these patients are hypoxic, they need non-invasive ventilation, they sometimes are on invasive mechanical ventilation, and there is no space to put in a drain because the lung does not collapse enough. Because the underlying lung is so fibrotic, there is no scope for the lung to collapse. You have pneumothoraces which are 10 to 20%, and you run the risk of putting in a pigtail and hitting the lung with it. So there, I think what Vrushali said is very important. High flow mask, non-rebreathe mask. Maybe if you have HFNO, then HFNO with a low flow rate of something like 40-45% with whatever oxygen is required to maintain oxygenation, or a non-invasive ventilation with a PEEP of no more than 4. You use what IPAP you have to use, but the EPAP should not be more than 4, and you maintain oxygenation that way. So that is a challenge that we have faced during the COVID times. And maybe Vijay was alluding to that, I think, in my understanding. That's a big challenge, though. That's a difficult question to answer.
Yeah, and what I take from you is that message that we should be training everyone. So the periphery is also to put in intercostal drain. So we should not be losing patients just because they had a pneumothorax. It's a completely treatable condition. And I think, sir, it's upon us.
It's an easy skill, Vrushali. I don't think it's a difficult skill to put in a drain. So I think everyone should know how to put a drain in an emergency scenario.
So this one transplant which we had recently, sir put up, Dr. Abhyankar put up. This guy came from a good place. It's not a periphery village or something. On 60%, he was an NIV with a saturation of 66. He traveled from a place which is 3.5 hours away from Pune, a city. So it speaks of, yeah, I think we need to train more. So
No,
the first thing which I know, he was,
agree.
yeah. So the moment I put in a drain, he is like, he was like, for me, you are the savior. I'm like, yeah, it's your destiny that you reached up to me. Otherwise, anyone could have just put in a needle, and I have told this to all my students that if you do not know, do not wait for me. Just put in a whiteboard needle, connect it to underwater scene. Most of the time, the patient settles. Okay. Sir, just answer this question from Mahesh Kumar from Lexington. That is, do you come across pneumothorax or pneumomediastinum with NIV for COVID patient, even with the modest setting? So before Sir gets to it, I can tell you that some patients have presented with pneumothorax despite not being even on oxygen. We have had pneumothoraxis and pneumomediastinum for patients who have been on plain oxygen, not even high flow oxygen. So I think we do come across this. As Sir rightly pointed out, that what we are doing is that we're using high flow oxygen for these people. And in most of the cases, if it is 10 to 15%, masterly inactivity works for such people. And a couple of cases which I came across where they put in a drain, they didn't find a leak any place. They put in drain, the patient eventually had infections and died because of that. So this has been our take at our center, that we are generally not treating aggressively unless it is causing a hemodynamic compromise or it's worsening the respiratory status really bad for the patient. So they do well on conservative management. Next is from Dr. Ajay Lanzevar from Nagpur, that how do we decide that NIV is not working in cardiogenic pulmonary edema? Okay. Sir, I think it is the worsening respiratory status. The patient getting to fatigue, you will have, you might even start becoming drowsy because you have a badly uncontrolled hypoxic respiratory failure. They eventually, because of the muscle fatigue, they start mounting carbon dioxide. And so these are the early signs that the patient is not being helped by an NIV. Plus, at the same time, if you see that the cardiogenic edema keeps on worsening, so you start getting audible rals at the throat and all, so the NIV is not working. I think we should not wait up to that time. It's better to intubate such an individual early.
Yeah, so Vishali agreed. Absolutely agreed. I just will add a couple of things more. So I think you understand that like any other condition, it's not just the NIV that you're treating, Ajay. You're not treating heart failure just with non-invasive ventilation. You've probably got a Lasix infusion going. You've probably got a GTN infusion going if this patient is hypertensive when they had failure. And this is one condition where the response is early. So if your patient is no better or worse at 1 to 2 hours after initiation of non-invasive ventilation, it's unlikely that this patient will get better with what you're giving them. Because, heart failure treated well gets better very magically. I mean, it doesn't happen as magically as pneumothorax does, which Vishali spoke about just now. But between a COPD getting NIV and a cardiogenic pulmonary edema getting NIV, the NIV person actually gets better much sooner as compared to your acute exacerbation of COPD. So in these cases, ventilate early, like Vishali said, because ventilating early and giving them a higher PEEP is probably going to make the patient better sooner rather than wasting time by giving the non-invasive ventilation for long hours, which might actually reduce the PF ratio to an extent that the patient goes into respiratory failure or has a respiratory arrest.
The other reason which I can just point out is most of the times if this patient is not settling, if you're giving a good dose of diuretics and the inodilators, is usually these patients have an associated acute kidney injury, and that worsens the condition. So I think invasive mechanical ventilation till you get all these three sorted out. Okay. Now, how do you select the different modes we've done? So could you illustrate more upon what is the ventilator-induced diaphragmatic dysfunction, VIDD? So this is a question from Dr. Tejas Gude from Mumbai.
So ventilator-induced diaphragmatic dysfunction is sort of goes along with, this new term, not new, it's been there for ages together. But again, like lots of other things, it is come into fore with COVID, which is SILI, which is sort of ventilator-associated lung injury, positive pressure-induced lung injury. So the diaphragmatic fatigue and the stretching of the diaphragmatic muscles that you get with prolonged periods of non-invasive ventilation, the flattening of the diaphragm and hence the hyperinflation that you get in patients who have long hours of non-invasive ventilation is something that we see in a small fraction of patients on long-term NIV. And I guess that's what you have with the VIDD. I'm not completely sure about how you go about combating this in the small fraction of patients. I guess the weaning procedure needs to be with breaks in between so that you can prevent VIDD from happening. But I'm not completely sure whether putting in things like a diaphragmatic pacemaker in these individuals help in the long run or not. But your take, Vishali. I wouldn't be able to tell more on that topic as compared to what
So as you rightly said, that anything which has not been used for a long time, so it is like a disuse atrophy kind of thing. So the ventilator-induced diaphragmatic dysfunction will be because of that. So where it is feasible, yes, you have to give breaks on your NIV. So you have intermittent non-invasive ventilation, so the diaphragm starts working and doesn't lose that. Yeah, I have to be moving up and down. So that is one. I think it would be a little far-fetched to think in terms of using a pacemaker for this condition. I think so. Basically, and maybe less use of your paralyzing agents, which is another thing because of which your muscular dysfunction can occur. So these are the two things on my side. That one,
so this is
intermittent breaks.
Sure. So this is we're talking about non-invasive ventilation. So there's no question of a paralytic. And when we spoke about, the other thing I wanted to say was this is the diaphragmatic pacemaker we're talking about.
Yeah, diaphragmatic pacemaker. Yeah. I am speaking about that.
Yeah, so diaphragmatic pacing.
I personally feel
diaphragmatic
this is a condition which is reversible. So maybe, you start weaning the patient at that point of time. Whenever you have this VIDD, you start weaning of the patient and eventually the diaphragm will regain its lost function is what I think is possible. So we haven't come across so if you have come across, how have you managed such a case of VIDD?
No, it's the same. So diaphragmatic pacing is a research tool, not just in VIDD. It's the same in patients who have diaphragmatic weakness from neuromuscular disorders. So it's still a research tool. It's something which is not available in the general population. So I guess weaning being preemptive is something that you do, but there's a contradiction of terms, Vishali, because on one hand you're saying that the patient is on non-invasive ventilation for a long time because you cannot get the mask off. And on the other side, I am saying, or you are saying, that you take the mask off quickly and wean the patient quickly. If you manage to do that, you would have done that already. So VIDD as of today is a difficult condition to treat. It's a challenge because it happens in the first place because weaning is difficult. So
So is it that with now the availability of HFNO, we could have an intermittent NIV and an intermittent HFNO, and that can probably prevent this kind of an occurrence? Okay. In a patient on ICU ventilator, this question comes from Dr. Dayanand from, I do not know. In patients on ICU ventilator, NIV with a pressure support is being shifted to now home NIV. How do you adjust the IPAP and the EPAP, and how to accommodate the pressure support used?
Okay. So if I understand that question correctly, so
how do you down?
So suppose you've got someone who is on pressure support on a ICU ventilator, has a pressure support of 8 and a EPAP of 4. So your IPAP in that case on the BiPAP would be 12 and the EPAP would be 4. So 8 plus 4 is 12 and the EPAP would be 4. Your PEEP would be 4. The challenge is not with setting the IPAP and the EPAP. That's easy. If your patient is on an NIV because the patient is very hypoxic and needs higher amounts of oxygen, it would be well nigh impossible to do that with a BiPAP. The BiPAP, if you go by Vishali's lovely calculation a little while ago, and you calculate as 1 liter being equal to 4% above 21%, which is your normal air FiO2, the maximum FiO2 you can go up to is somewhere between 35 to 40%. You wouldn't be able to give FiO2 of more than that. So if your patient is on a hospital, on an ICU NIV with 60% FiO2, however skillful you are or however good your BiPAP is, you will never be able to achieve the same degree of oxygenation with the home BiPAP that you're using. So that's the challenge.
Absolutely. So that the question from Dr. Rajvinder Kaur and Dr. Dinesh Saraswat, one is from Ludhiana and Dr. Saraswat from Ghaziabad. No, sorry. and Dr. Sandeep from Gurgaon. So their questions are almost similar. That is, how do you prefer to setting about NIV pressure control versus NIV pressure support mode? And can these two be used interchangeably? Kindly differentiate between the two.
You want to have a go, Vrushali, or do you want me to give a quick answer?
You do the honors, sir.
Yeah. So pressure control is not really a mode to be used in non-invasive ventilation. So pressure control is normally an invasive mechanical ventilation mode. However, in certain places, COVID for instance, where you are desperate not to intubate a patient and your patient is hypercarbic and you want the ventilator to take over, you might use something like a drug like dexamethasone, for instance, trying to bring the respiratory rate down and put the patient on pressure control with a higher respiratory rate in trying to get rid of the excess carbon dioxide of the body, from the body. It's a risky strategy. It's not a strategy that I am recommending on this platform today, but a lot of intensivists, a lot of pulmonologists would do that in scenarios where you are hypercarbic, but you still want to avoid invasive mechanical ventilation for whatever the reason might be. The pressure support is the normal standard mode of ventilation when you're using non-invasive ventilation. And I would advocate that in most situations, that's the modality of ventilation you should use when you're using non-invasive ventilation, as opposed to invasive mechanical ventilation, where pressure control and pressure support is a continuum, is a weaning mode. You start off with pressure control and then go to pressure support and wean the patient off before you extubate.
So I believe what he wants to say is that when you do not have these dedicated non-invasive ventilators in the ICU, you have these invasive ventilators which have a non-invasive modality. We have seen in certain ventilators, like one he's speaking about is MACE, and this where you have NIV PSC, NIV PCV, NIV VCV. So I believe they want to ask in that which one should be you choosing and whether it really matters what you're choosing in such cases.
It does, I think. So I think what you would want, at the cost of not repeating myself again, I think your mode of ventilation should be pressure support when you're using non-invasive ventilation. Pressure control would be only in scenarios where your patient is hypercarbic and you want to overcome the respiratory drive of that individual and try and drive carbon dioxide out by increasing the respiratory rate in these individuals. And you wouldn't normally use pressure control. And no, I think what Vrushali was trying to emphasize, and I do the same, is they are not to be used interchangeably. You stick to one particular mode. Pressure control is a rarer mode in any form in non-invasive ventilation, and pressure support is something that we would normally use.
This is from, just a minute, from Dr. Dhanisha Hanam Konda. How is NIV helpful in IPF and what is the mechanism behind it?
That's a good question. I think I had a slide up. I mean, I'm not sure whether you guys could actually so I would be very happy to share these slides. I had a slide on use of non-invasive ventilation in ILD. So non-invasive ventilation use in ILD is controversial. It's controversial because it doesn't really result in improvement of mortality. You can use it as a palliative tool. So patient who is very breathless, requires greater amount of oxygen, you could use the non-invasive ventilator for that particular purpose. You could use non-invasive ventilation in ILD, trying to avoid invasive mechanical ventilation, where non-invasive ventilation is the ceiling of care, as it should be in most patients with end-stage ILD, for instance. So there are various indications. There's a couple of lovely review papers that I spoke about in one slide. Have a read of these review papers. It's restricted use in ILD, but there is a small place which is mainly palliative rather than with the intent of cure.
Yeah, so palliative as in you reduce the work of breathing and this make the patient a little more comfortable in his end days.
Correct. And oxygenate the patients better, Vrushali, along with that.
Yeah,
sure.
Okay. Sir, before I go to, I have this question on where do you prefer a helmet mask, and how do you go about the logistics about the helmet mask, and are the settings different on the NIV in such a case? Or, because there's a lot of room, 10 to 12 liters is present in the mask itself. So how do you manage a helmet mask? I have these, I've never come across a helmet mask, and I would really like you to elaborate on this.
So, Vishali, we have started using helmet masks during the COVID-19 pandemic, right? So that's my first experience, even though they have been around for longer. That's when I've started using the helmet mask. Let's talk about positives of a helmet mask first. So the positives about a helmet mask is that it's much more comfortable as compared to the full face mask. The pressure ulcers that you get over the nasal bridge, that you get over the maxillary bone, over the chin, etc., the tight straps that you have are all gone when you have a helmet mask. When using non-invasive ventilation for long hours, a helmet mask is a boon in a way. I don't think there are separate indications aside from the fact that it should be used in individuals where we discussed before, you cannot take the mask off. It's difficult to take the mask off. There, a helmet mask is a good thing to use. What is not so good about helmet masks? So the first thing is that there's an entrained dead space within the mask. So you have got about a 150 to 200 ml entrained dead space, which is within the mask, which is wasted ventilation in these individuals. So that's one problem that you have. The second is feeding is a challenge. It can be through the feeding tube, but the problem is that some of these helmet masks, especially the Indian ones, don't have the outlet for the feeding tube. So you have to actually take the helmet mask off and then feed the patient, even if it's through a feeding tube, even if it's through a Riles tube. So that's the second challenge. But you have the Italian version, so came in with the original mask, where you have an outlet through which the Riles tube can actually come out. The other problem with the helmet mask is some individuals who are claustrophobic find the helmet mask very, very closed and very, very claustrophobic. So that's another challenge. It requires a lot of reassurance and time from your side when you're putting in the helmet mask for the first time in making the patient understand what you're doing. It's even more than what you do with a full face mask. Time needs to be spent with these individuals. But I think, Vishal, if you've not used a helmet mask, there's a definite place for it in therapy. It's not for everyone, but in your patients who are requiring high amounts of oxygen and need to remain on an NIV mask for long periods of time, it's definitely the way forward. There are Indian versions which have now come in, which are far cheaper than the Italian version, which is prohibitively expensive even for a corporate hospital where I work in. But the cheaper Indian ones are good. They're not as great as the Italian ones, but they're good enough. And do use them when you cannot get your patient off the mask for long periods of time.
So the other question which I had is that if you have a helmet mask, does it change your settings, the ventilatory settings?
Sure. So pressures need to be a little bit higher because you've got this entrained dead space, Vishali. The pressure needs to be higher, especially the EPAP. The PEEP needs to be slightly higher as compared to what you do with an orofacial mask or full face mask.
Yeah. So then how do you know that I have achieved a good enough PEEP? So the tidal volumes and things will be there. So how do you know that? Is there a particular formula by which you do it?
No, there isn't. There isn't. What you said, your sort of 6 ml per kg body weight of tidal volume, which you're trying to achieve, is true here. So I guess you sort of tweak the IPAP and EPAP in a way that you reach above that 6 ml per kg body weight of tidal volume. You need to generate that with the helmet, and you will see that you need slightly higher pressures to reach that. I understand your question, but I'm not aware of a formula which will help you to reach that particular level. I think you just tweak the knobs and reach that particular level.
Yeah, so I mean, it will be coming more with your practice as to what is the adequate ventilation. Sure. Another thing is, if you use a humidified air in this, is there any kind of discomfort to these patients?
So a humidifier is difficult with a helmet mask. I mean, in my limited experience with helmets, I have struggled to use the humidifier because the humidifier makes the mask fog off to an extent. You get small droplets which go on the inner wall of the helmet mask, especially the Indian version, and it becomes very clouded. It becomes fog. It's like when you're trying to drive through smog and your wipers, if they're not working, you cannot see very much. So I think that becomes a bit of a problem with the humidifier when using it with a helmet mask. That's a good question, Rushali. Well thought.
Now, there's a question from Dr. Saurendra Nath Banerjee Burdwan. In COVID, severe hypoxemic patients on mechanical ventilation and still the oxygenation is not rising. How much PEEP can you give maximally? There's no prior history of any lung disease, that is COPD or asthma.
So I don't think, short question, Saurendra, good to hear from you. Short answer, I don't think raising the PEEP, especially if the lungs are fibrotic, would help in any way. In fact, it might actually be to the detriment of the patient. You might actually cause these pneumothoraces and pneumomediastinums that we were talking about a little while ago with a high PEEP. So I don't think PEEP really helps in patients who are on a high FiO2 with a reasonable IPAP, reasonable respiratory rate. You're still not managing to generate a tidal. Increasing the PEEP probably only increases the risk of a pneumothorax rather than improving ventilation in any way.
And so this question from Dr. Komal Kumar Jangir from Mandawara, that is how is to set a trigger or a rise time?
Yeah, so I mean, I would, we were discussing this briefly, weren't we, Vishali, before we started off. So I think what we need to do is to understand what the rise time is. So the rise time is set. So it's the pressure increase from EPAP to IPAP, and the range is fixed from 1 to 6. So your range between the EPAP to the IPAP is in 6 steps. Each of these is 0.1 seconds. And what I want you to remember, all of you to remember, is that it acts as a comfort control for patient. And if you have a patient who's got a high respiratory rate, you go for a low rise time, or 1 or 2 as a rise time. Whereas if your patient has a normal respiratory rate or is hypoventilating, you would go for a higher rise time. So I'll say that again because I think this is important. This is all you need to know about rise time or triggering. So it's how quickly the pressure increases from EPAP to IPAP. The range is between 1 to 6. Each of these steps is 0.1 seconds, and it acts as comfort control for the patient, and short rise time for high respiratory rate in the patient, and vice versa for normal respiratory rate or patients who hypoventilate. So that's my very sort of idiot's guide to rise time. I wouldn't go beyond that. Most of the machines would give you the rise time, and your technician or the nurse in the CCU probably would be able to set the trigger time or the rise time better than you and I could. That's my guide. That's what I understand by rise time, and that's what I do when I adjust rise time on the ventilator.
Usually what it's seen is, usually it's between 0 to 0.4 seconds is the rise time which is there in the cycles. Correct. And or you have the percentage that you achieve it in 0 to 20% of your entire breath cycle. Right, sir? Correct. So I think that was the last question for the day. And so though we wanted to finish early, I have ensured that we finish at 10 o'clock as Krishna sir wanted. I'm sorry if I've missed out on any of the questions.
No.
So I'm sorry because, you know, it is, for me itself, I mean, I love getting to be taught every single time, and who better than Dr. Rajadhar? I mean, it just, it's like everybody else, we just love hearing you talk because you are so lucid. I mean, you know your concepts so well. So this is this plus this, so it's 1 plus 1 is equal to 2. As simple as that is how you simplified the things for us. And I think it has been a lovely session. A special thanks once again to CCI, Dr. Dhar, all the CIPLA team for ensuring that the webinar goes through smoothly. And I think good night to everybody. So
Vishali, absolutely delighted to be here. Really delighted to be interacting with you. I learned a lot, honestly, speaking to you. It's been very, very nice to speak to everyone on the CCI. I'm sure we'll catch up again at some point of time. A big congratulations to you, to Dr. Krishna, Atri, who is actually instrumental. So even though I'm not on WhatsApp, Atri takes the pains of sending me all the messages by email so that I can remain in touch. So a big thank you to Atri. And you guys are great. You guys rock. I hope to have many such master classes which are of similar ilk and similar nature. And thank you very much for having me.
Thank you. Thank you, sir. Thank you so much. Bye-bye.